Thank you, Shri Priya. Good evening, everyone. Good evening, and welcome you all for today's session. With utmost pleasure, I welcome Dr. Nandini Vallath, ma'am, who is a professor and HOD of the Department of Palliative Medicine at St. John's Medical College and Hospital, Bangalore. She's a palliative care physician who is actively involved with clinical, educational, and policy reform activities at national level. She is an editor of the third edition of the Oxford Handbook of Palliative Care, which won the 2021 BMA Medical Awards under the Hospital Medicine category. As a consultant of Palliative Care Division with the National Cancer Grid India, she coordinated the development of first edition of palliative care guidelines for 210 cancer care institutions networked under the NCG across India. She has been directing the Equip India training of the India Quality Improvement Hub NCG in collaboration with Stanford Healthcare USA since 2018 and convenes Impact HN that integrates palliative care modules into the multicentric orofacial maxillary surgical oncology fellowship training. Thank you so much, ma'am, for joining today. And over to you, ma'am.
Good evening, and thank you for warm introduction.
Thank you.
As mentioned, I think it is one of the important aspects which we need to know when we are entering the field of palliative care. Is my audio clear and my slides visible?
Yes, ma'am.
So, the Narcotic Drugs and Psychotropic Substance Act, you may have come across during your undergraduate days, while studying pharmacology. But we really come face to face with it when we are using the medications for managing chronic pain, as seen in cancer patients. So let's see, why are we even discussing this act, and what we should know about it as practitioners of chronic cancer pain specialists. So this is a very famous photograph, property of Dr. Rajgopal. So this patient had a very severe pain in the epigastric and radiating to the back due to cancer of the pancreas. And he was given one tablet, 10 milligram morphine, and he sat up to have some tea, and the first question he asked was, why was this medicine not given to me earlier? Because he had gone to several clinics and doctors and requested for pain to be relieved, and he had been in that positions for weeks without being able to straighten up. So we are discussing this aspect, why patients with severe cancer pain are denied of timely medication, and why it has happened, and how we looked at it, and currently what is the situation for you to work on. So I would like to hear from you, if possible. Just put it into the chat. Is there anyone here who uses morphine in their day-to-day practice? So I request Shri Priya if she could read out some of the responses, because I have shared screen. I can't see the chat.
Yes, ma'am. We are getting S.
Many of them have used tablet morphine in their day-to-day practice. That is my specific question, not the injection.
Yes.
Okay, so several of you are using tablet morphine. And also, I would like to be silent for a minute and see what you think that you learned through this class. Just a minute, and just mention a word or a bullet point so that we get an idea of what is expected.
Ma'am, around 3 doctors have mentioned no for the tablet form.
Okay, but everybody has responded. It must be a small proportion which has responded, right?
Yeah, ma'am.
So we'll assume that some of you are using and some of you are not using. And is anyone responding to what do they look forward to in this class?
No, ma'am.
Okay, fine. We'll go on. So what I hope to do today is to discuss the main features of the NDPS Act as it used to be, and then talk about some of the amendments. then how we as working in different institutions can get recognized. RMI stands for Recognized Medical Institutions. So as a trained clinician, now that you're undergoing the fellowship at Pallium India, you will have to show the proof of training in using using tablet morphine, and your institution where you work can become an RMI, and we'll be talking of how that is done. The competencies, suppose you are in charge of that RMI wherever you're working, what are the requirements of you as a doctor in charge of the RMI? And despite all this, currently, although the NDPS amendments have happened, there are some concerns, and it has not become freely, operational across India. And still, there are huge, huge regions. In fact, I should say a very small region, very small areas of India has implemented the amended act. And then what is our role in managing the barriers and in ensuring a balance between improving the access and preventing misuse? Okay, so this will be a kind of framework through which I'll be discussing today. So narcotic psychotropic substances have entered into the WHO essential list of medications and the India's national list of essential medications, and in the pediatric list also, because you know that narcotics are completely useful in acute and emergency care, in myocardial infarction, post-op pain, left ventricular failure, then in management of severe pain, and in management of intractable symptoms, especially that we use in palliative care. And it's also used when patients are using it as there is non-medical opioid use, and we can use it as substitution therapy. For all these reasons, they are part of the essential list. But still, our patient did not get it, despite, going to multiple regions and multiple clinics, isn't it? So there was a study done across large regional cancer centers in India, four of them. It was done, and then they studied a sample of 1,600 patients with cancer. These are all cancer hospitals purely, and they are, old cancer hospitals, and all of them had palliative care departments working active in their own institutions. They sat outside, the researchers sat outside the OPD, and they looked at the pain management index score. Okay. And what they found was majority of patients attending the Indian regional cancer centers, they experience significant pain and inadequate pain management. Okay, so a little more detail about it. This was published, as you can see, in the Journal of Global Oncology, ASCO's journal. And they saw that while the pain is in the minimal or mild and area, there is reasonably good prescription given. But when the pain becomes moderate to severe, you can see that the adequate prescriptions kept coming down, and the inadequate prescriptions or even no prescriptions were climbing up. So the doctors were unaware of handling moderate to severe pain because it is probably not part of our training. This was a very, very landmark, clarity on what is happening in India, because they study and they had not referred any of these patients to palliative medicine. So this was very high incidence of pain and very poor prescription practices. So what they found, so the studied RCCs were the ones in Kolkata, MNJ Hyderabad, GCRI Ahmedabad, and the Cuttack one. And they saw that nearly 90% of patients had moderate to severe pain during the OPD visit, and 80% of those with pain had inadequate prescriptions when they came out of the consultation. So they were interviewed prior and they were interviewed after the OPD consultation in a cancer oncology OPD. Okay, so this is the elephant in the room, unresolved cancer pain. So while the tumor board meetings discuss various therapies, the reason for which the patient came, which is severe pain, is neglected. Okay, and the person continues to be having severe pain. So now, what is the association between the regulation and, we are saying that patients are not getting pain? How does the law come into the picture? We will just look into that. And, why did we amend? Who can stock and dispense and, further things which I do. So all this happened because there were very stringent laws in the country, which did not allow clinicians to use narcotic medications. And all this started with the British Raj. So in 18th to 19th century, opium was a trade crop, and all the laws, the opium law made by the British were mostly to monopolize, and the language was to prevent others from accessing opium as a trade crop. So every region around India, so the central part of India was where it was cultivated, where the soil and climate suited, and even within India, if you had to move the medication. This is that time it was not medication; it was used, abused. It was meant as an addiction drug, and even if you had to move, you had to have import license, export license, transport license, and all of that used to bring in money to the British administrators. So all these taxes created a lot of money, which, according to some of the papers, supported 1/6 of Britain's economy. This work in opium as a trade crop for creating more and more addicts. And this continued up to early 20th century. Nishant, can you please mute? Nishant, I request Priya to mute Nishant. Okay, so in the 19th and 20th century, so up to 19th, it was even legal, to use opium as a trade crop. Then the various sensibilities of the global power leaders during that time opened out, and they declared opioids as drug for abuse. And then all the law became stringent. Instead, initially it was for trade and monopoly. Then it was the war against drugs kind of attitude, and the need to eradicate drug abuse dictated policy language. Now you can see that in between 19th to 20th century transitions, very powerful countries like Britain were heavily invested already into this trade, and they continued the smuggling despite these kind of sensibilities coming up that we should not subject more and more people. So the biggest brunt was borne by the Far East countries, who had a tendency to inhale or inject this opium, whereas in India, this kind of trade pushing did not affect, because Indians had a history of oral intake, which did not, because the khaskhas and all those different bhang and all, people had an oral way of taking, which did not cause that much of an issue. Whereas almost 30+% of young Chinese became addicts, and there were wars, which was called.
Yeah, I have placed my phone for battery.
19th century.
Oh, it's already getting serviced?
Yeah. That opium wars is where Britain gained Hong Kong from China as damage control from China to Britain. So all these big histories there around opium. So you can see that from opium as a trade crop to opium as a drug of abuse took time. And it was quite late in the middle of 20th century that actually the countries which were profiting slowly eased out of this trade. And they were, the single convention, the happened from the United Nations. You can see it happened only in 1961. And they said that now, the narcotics have medical use. So ensure its availability for medical and scientific use while preventing diversion and abuse. But because of this heavy history of, 200 years of addiction, most countries looked at preventing diversion and abuse. Okay. So all the laws, till then there were no laws at all. After this 1961 single convention from WHO, most of the laws focused more on preventing misuse and diversion. And this whole idea of using it for safely and rationally for analgesic was kept in the background. So you can see this doesn't have India. I'll show you another one. So this is a person who had done a lot of work on narcotic policy. And you can see so many countries had so many sets of barriers, of who will be eligible. Emergencies are not given, or just given for 2 days prescription. So those kind of various bureaucratic as well as medical barriers existed in many countries. And in India, the NDPS Act, Narcotic Drugs and Psychotropic Substance Act, you can see this year, 1985, that was when I think Rajiv Gandhi was the Prime Minister. And this 1961 convention had mandated that every member state of WHO, which included India, has to come out with a law within 25 years. So they had given 25 years to each country, and India responded almost at the fag end of 25 years, because 1986 would have been the completion of 25 years. So what they did, they took the Opium Act of British, which was primarily meant for monopoly, and they just copy pasted that and made it our law. So it was, and it was only titled as Preventing and Combating Abuse of Illicit Traffic. That was how it was done. There was the main central provision of the act was mainly to prevent abuse and illicit traffic of narcotics drugs. So when my uncle passed out in the 60s, he had seen tablet morphine. But when I passed out in the 90s, there were no tablet morphine, okay? Because the law had come in since so many years, and all the medical institutions, they preferred to take away that from the pharmacy because there were so many different licenses required. I'll just talk to you about. So preventing misuse and diversion was the primary intent. And this NDPS Act, had multiple agencies in different states. Each state had made their own provision. Some used excise department, some used food and drugs, some used drug controller. And there were multiple licenses, as I told you, because Opium Act by British had import, export, interstate, transport, possession. 6 licenses, and all of which had an expiry period of few months. So each time you have to keep renewing. And if you don't have all of them active and, suppose you find any of them that, they're expired, then the institution will be responsible. And it was, like 10 years of rigorous imprisonment. So which institution would take a chance? So all of them prefer to take it away from their pharmacy. Some states even had quota systems, and some states, like borderline states, like, Punjab and all, they said, we don't use narcotic, we will not have laws. They didn't even have a way in which medicine could be acquired by a patient who is, ill. So there were so many barriers. So it was almost, that is the reason that, all this was happening. After the act came, after the 1985 act became penned down. So it became low priority for government department to make it accessible for medical use. There was no provision at all in the act. There were so many complex procurement procedures. Now you'll understand that I just mentioned the 6 licenses. And doctors like me, we had no training. Who passed out after 1985, we had no exposure to tablet morphine. Only thing that we saw of morphine was injectable form used in emergency and in the theaters. So we had no training in using it for chronic pain. So obviously we don't know what to use, and we assume that all the side effects which happen with injection morphine will happen for a tablet morphine. So there were misconceptions about the benefits and risks, and there was threat of harsh punishment, because whether you are an illicit user or whether you don't have one license or, one paper missing, the punishment was the same, and it's still the same. So 10 years of rigorous imprisonment. So what happened is everybody stopped stocking. So the pain was undertreated. Doctors forgot how to use morphine, and there was poor demand from professionals as well as public. So a person with severe pain was expected to be, you are having cancer, so you'll have severe pain. This was the state. Okay. So now there was ensuring was very low priority and preventing was very heavy. Now the whole amendment was to make sure that, so from the 1985 till now, our aim now, so monopoly has changed to eradicating drug abuse, and now all the efforts are to improve access for medical use. So the policy mandates and the language now has transitioned into, it's a very important analgesics and we have to make it available. And now that you all have done the global fellowship, you must have seen how useful this drug is. Okay, so there has been a lot of work done to make this happen, and including multiple across the country. So TIPS and Pallium India have taken lead in creating a lot of awareness across countries, running opioid availability workshop. There has been public interest litigation. There have been lots of advocacy, and there has also been, awareness creation. So now this NDPS Act, you can see how thick that book is. So now it is amended in 2014 through a parliamentary act of Lok Sabha and Rajya Sabha. It got amended. So we'll just look at what did we do to make this amendment useful for medical practitioners in the field of palliative care. Okay, so the aim was to balance of access and availability and yet prevent misuse and diversion. So as you know, this was the single, edged act which was only preventing, and this slowly became the fourth section, which had the central scope of the act, now had this added to it. So this was one amendment. So preventing misuse and for ensuring medical and scientific use. So the purpose and scope of the act expanded. That was a crucial thing because the rules can form only if that scope is existent in the original act. Okay. So now another thing that they did was, so first of all, they added that. Second thing was the power to make rules, as you know, was with all states. Every state could make its own rules. So now it became a central activity. The power to make rules of, transport, purchase, sale, import, everything became transferred to the central government. So there was a uniformity in the NDPS rules. It was no longer regionally dependent. Third thing was they identified a single state agency, the drug controller. You saw that it was earlier different people, FDA and excise and all that. Now only a single agency across India was authorized for recognizing medical institution. I told you they called RMIs for stocking and dispensing opioids. So this was given to single agency. So again, one more confusion less. Then this NDPS Act contains 100 plus drugs. We don't want to amend the law for everything. We just wanted it for essential drugs which we use for pain management. So there was a new category created called essential narcotic drugs, which the central government can keep notifying, because suppose there is a new discovery and another essential narcotic drug comes in, this list can keep on getting modified. So this essential narcotic drugs, what are they currently? They are these 6 drugs: codeine, fentanyl, hydrocodone, methadone, morphine, and dihydrocodone, codeine, and all their formulations. Okay, it's not just these, all their formulations. So in this, except for hydrocodone and oxycodone, that is dihydrocodone, all the other drugs are available in India. Those 2 drugs, preemptively, the pharma companies ensured they entered the essential narcotic list because they're expecting them to be soon made available in India. So currently the END category contains 6 drugs. So just to summarize, expansion of scope of the drug from only containing illicit use, but to also promote medical use, central rules and not state level rules, essential narcotics as a new category, and state drug controller. Okay. Now coming to who can possess ENDs. So any guesses from the students about who can possess essential narcotic drugs? Who is eligible to have narcotic drugs with them?
Ma'am, there are few responses in the chat. Anesthesiologists, RMI status, and those who has license for it.
Yeah.
Then
Okay.
registered institutions.
Yeah. So RMIs and registered institutions, I guess they mean the same, recognized for holding it. So RMIs are one set of, who can possess, and registered, all of us with an MBBS degree, we are also allowed to possess, but in very small quantities, not to the quantity that we dispense for cancer patients, because we are expected to treat emergencies for which it was, even in MBBS, we are aware of it, but we are not supposed to hold it in larger quantities, and I'll tell you the quantities. Third category is the patient who has a valid prescription for the drug. Okay, so these are the 3 categories which can possess ENDs, and we are interested in all the 3. So we'll talk a little more about it. So first we will go to the registered medical practitioner. So even if you did not have global fellowship or you're just an MBBS doctor, you're allowed to hold these drugs, but you can see just 500 milligrams of morphine. So each of them have their own limits. Like for example, a patch also, just 2 patches you can hold. So these are all for, suppose you see a traffic accident and patient is in a lot of pain, you should be able to give 1 tablet and you have to put a patch or something. So it is for your use in practice, and you are not allowed to sell. This is for helping patients in an emergency setting in case your seeing a trauma patient, or in your clinic you see severe pain. So this does not require an extra license, but you are only allowed to use, as you can see, a small quantity of these drugs. So I hope this is clear. And now we are taking this out of our way. We'll move on. So this, I just told you all this. Larger quantities than these, which are mentioned here, require special authorization from the drug controller. Okay. Now, authorization, this is now RMIs. Authorization has to come from the state drug controller, and the medical institutions, they have to fill in an application form, show a doctor who is trained in using morphine or other ENDs for managing chronic pain as seen in cancer. And then once you have an authorization from the state drug controller, you do not need multiple licenses from multiple agencies for ENDs. Okay, so one authorization lasts for 3 years. So these, every few months, the hospitals had to employ a person to keep on renewing these licenses. So 6 licenses: import, export, transport, etc. So those licenses, you do not have to maintain them as an RMI. You can just have 3 years of authorization, and then you can renew it in the name of a person who's trained in using it. Okay, so what does medical institution mean? So it's a very flexible definition. It means a hospital. This is, I'm showing parts of the rules. Okay, so they have defined the medical institution under which RMI comes. Recognized medical institution. No, medical institution means hospital, dispensary, clinic, or institution by whatever name that offers services and facilities for treatment and care of injury and diseases, established and administered or maintained by government, municipal corporation, Zilla Parishad, or any person or body of persons. So literally it covers a small clinic to NGO-run institutions, to private hospitals, government hospitals, and across the healthcare system. Okay, so all of these come under medical institution. And recognized medical institutions means recognized under the NDPS amended rules of 2015. The Act was amended in 14. The rules came out in 15. And the registered medical practitioner also they have defined. So it can be a doctor under MBBS or a dentist, but there is a difference. So registered medical practitioner is to be registered with the Indian Medical Council Act, that is MBBS, or registered as a dentist under the Dentist Act or under the law, and has undergone training in pain relief and palliative care for prescription of ENDs. Okay, and the only difference between MBBS and the dentist is that they can only prescribe the medicine for the area that they are trained in. So a dentist cannot prescribe a medicine for a CA pancreas pain, for example, because they are not trained in it. But they can do it under, if there is another MBBS doctor who is supervising them. And the MBBS doctors can treat all pains which require narcotics. And then who can sell? Of course, the dealers, chemists, the RMPs with a special authorization, not the one where we don't have any license. Okay, you can only give it out of empathy. And then person who has been authorized by the drug controller and an RMI. Okay, the licensed chemist can also sell, but they are subject to both NDPS Act as well as the drugs and cosmetics rules. Okay, so that is very important to know that. So recognized medical institutions come primarily under the NDPS amendment, which happened in 2014. So chemists and dealers are still bound by the state laws. So that is still something that is pending in terms of activism. So recognized medical institution, they have to have employed a doctor with RMI competencies. They should ensure something called minimum mandatory criteria. I'll just come to it. And they should activate the procedures as defined in the NDPS rules. Okay, so I will tell you more. This is the requirement. Suppose you finished your fellowship and you go back to your institution and you notice that your pharmacy does not stock it. So these are the competencies you need to ensure, this capacity you have to build. And then you can also be, your institution can also be recognized as an RMI with your name and the certificate of training that you get from Pallium India. Okay, so what are the minimum mandatory requirements? You need to have a double lock system. That means this is a cupboard, you can see. So the cupboard can be locked, and inside it there are multiple lockers. So this is tablet morphine being stored. So you need to have separate lock system. So this is mandatory. So it is because, if somebody opens the cupboard for taking a file, they should not be able to kind of misuse the drug. So this will be under double lock. So this is very important requirement. Second thing is you have to maintain a register where a daily record of the dispensed drug is maintained, patient details are maintained, and this whole thing, so it has to be available for 2 years because a drug inspector can come and check anytime. All this looks pretty scary, but it is not so. Once you get into that habit of writing all this, so you can see here that there is so-and-so patient who was dispensed medicine, and at the beginning of the day, there was 18,236 tablets of morphine. So as you dispense 10 tablets, number of tablets are written here, and then the drug from 18,000, it comes down to 17,000 by the end of the day. You have dispensed close to 800 tablets. Okay, so like this. And then this 17,856 will become the starting stock the next day. And again, you write the names and they just, what did you prescribe and how much you dispensed, etc. And like that, you have to keep a track. Usually the pharmacy maintains it, or in an NGO, there may be an assigned person who's maintaining it. So this has to be up to date every day. Okay. Now, this is the minimum mandatory requirement in terms of storage and record keeping. Now, what are the responsibilities of the doctor? Okay. So they have to be in charge. I told you, suppose the institution, for example, my name is there in the St. John's Pharmacy as the person responsible for prescription. So I am responsible for prescriptions and the quantity that goes out. And also I have to ensure that the pharmacy does not, run out of stock, because you treat a patient for say a few weeks and he has excellent pain relief, and suddenly you say there is no drug, and that person can even, commit suicide because, he cannot bear the pain coming back. And then we are also in charge of prescription and record keeping, which I just told you in the previous slide. We are also supposed to update and keep what is known about the subject. So best practices for managing pain and for medical use of the essential narcotics. So we need to know which type of pain to choose to treat with opioids. What are the right indications? Because the most important thing is selecting the right pain and selecting the right patient. How do you start the medication? How do you titrate? How do you monitor? And when do you change the drug dosage? Suppose there are complications, what is opioid rotation? How do you understand adverse effects and toxicities? And how do you step up the dose, or how do we come down and stop the drug? And how do we use it in terminal stages? All these we may learn now, but every time there is something new happening, so we have to keep ourselves updated. And then we have to also contribute to preventing misuse, because we are in charge of the drug. That means every patient whom we think will do well with opioid, we should also assess whether there is any addiction potential for that patient. So if a person is young, male, with history of, either cigarette, alcohol, or substance abuse, and there is history of psychological morbidity in the person or in the family, that person has a higher addiction potential, and then our monitoring will change. Then, so always trust but verify. So you will not give long-term medication. You will, ask the person to come back often, and you will do pill count, and you will also restrict the number of prescribers. So these are the rule actual mentions that and also we may not be the only person. For example, my department has 4 or 5 doctors. All of them are allowed to prescribe, but so all of them will be listed, but one person is overall in charge. And the overall in charge will be, endorsed on the certificate of recognition issued by the drug controller of the state. So the person on whose name or who's responsible for the RMI, that particular registered medical practitioner's name will come in the certificate of recognition. And whenever there is a change, suppose I resign or I retire and a new person comes, we are supposed to notify within 7 days from a date of such change happens to the drug controller. And with the new certificate, we have to apply. What are the duties? So as I told you, maintain a record, which I just showed you an example, maintain record of all receipts. So in our hospital, there is a booklet with 3 color prescription, white, blue, and pink. So all the 3 with a carbon paper, when we prescribe. So the 3 prescriptions, one stays with the patient, one goes to the pharmacy for them to keep a record, and the third one stays with us. So in case suddenly there is an inspection, all these areas, both pharmacy and our setting, my OPD, has enough proof that this was the patient for whom it was dispensed and this much was dispensed. Okay. So we need to have a printed prescription with certain requirements, and it should always be updated. So if you're doing things diligently, you don't have to worry. It will automatically be updated. Okay, so now we talked about these two. The ordinary doctor who does not have any training, they can also hold a small quantity. We talked about RMIs, and we should not forget that patients are allowed to have ENDs. It's very important that they should be educated to carry the prescription with them. So prescription should be having certain criteria. It should be in writing, should be dated, signed, with the full name, address, and registration number. And it should also specify the name and address of the patient, the total quantity of the drug, the daily dose, and period of consumption. All of this we routinely do, but in this, it becomes all the more important. Okay, so this should be informed to the patient that suppose they are traveling by air or they are moving across countries, they need to have the prescription along with the drug, otherwise they'll unnecessarily have a lot of issues with the customs. So prescription typically looks like this. Okay, so you have to write everything properly, how much and totally how many drugs were dispensed also should be written. Okay, so this is for patient safety. You have to explain to them because they may not know this requirement is there. Now, all this is enough. And what happened is many states started introducing new stuff that, there has to be an affidavit from the patient and all that. So then we went back to the center, Delhi, and then B.N. Sharma, who was then the joint secretary unfortunately for you all, I want to share that because it was a trade crop under British Raj, it still comes under the Ministry of Finance, under the Department of Revenue. This particular NDPS Act does not come under Ministry of Health. So B.N. Sharma is a ministry in the Ministry of Finance, Department of Revenue, and he sent this order in 2016 because people were creating, the states were creating new rules. So RMI will not require any additional approval or license to stock. So this happened, but still there are problems. So the amended regulation, I think I have explained to you that single agency, they are not restricted to pain relief, and training on medical use is linked mandatorily with stocking permission because there are so many medical practitioners like me who did not learn about chronic pain management during undergraduate and postgraduate days. Those who have come into medical medicine maybe after 2019 or so, they are more likely to have got some exposure when more and more palliative care units have opened in medical colleges. Now, another thing we need to remember that the law allows posting and couriering by rail or road, and there are certain requirements for it. Those who are interested can look into the rules. It's freely available online, and I'll also be sharing the sources which you can read. So you should also look into the IAPC site because, patient that you see today may go into another state. So IAPC site also has a directory. So you must look at the directory and attach them to another center, or you can follow the rules and courier the medications from wherever you are, because the person, if he goes to a place where there is no availability, again, there will be an interrupted supply and patient goes back to getting severe pain. So what we did through the amendment of the NDPS Act, or the amendment of 2014, was all these blocks which were existing, we tried to change, and there was a clear path through the act so that the patients has more access. So you can see that passing this will make morphine accessible. This came in February 2014 after the act got amended. But we are still sitting here in 2024, and many of you will acknowledge that there are 79 who are listening to this talk. Many of you will know that it is still very, very difficult to access morphine despite so many years having passed. Since almost like 10 years have passed since the amendment. So many things still are issues. So this is a study which was done by the in an article they have published this a daily dose of daily dose per million inhabitants. So you can see the Western countries which hold 20% of the population. How is their daily per million? How much are they using? 35,000, 16,000, 15,000, and now you see Sri Lanka and India. You see 96, 37. You see how poor 80% of the population are in these countries, but they use lesser than 20% of the world's production of opioid. So, and also in Western countries like US, there was a major issue due to indiscriminate overprescription of opioids, even for ordinary pains. Whereas in our country, even for cancer pains, there is poor access. And you can see the difference, USA, UK, and how India is 0.54, Kerala is slightly better. And all the other countries are, pretty poor. So here, according to the usage, they have created this map, and you can see where India is hardly seen in this map. So it's a huge issue where the powerful and, people who have better knowledge, they have access, whereas the maximum number of people inhabited in this part of the world, Asia, South Asia, etc., do not have access. You can see South America, Africa, Asia, whereas Europe, Australia, and Western countries, they do have good access to it. So the source is International Narcotics Control Board, WHO statistics published in 2015. Okay, so there is law that has changed in Delhi, but it has not reached many parts of India. Okay, now how do we help this? So I told you about B.N. Sharma, Additional Secretary of Revenue, who wrote that particular letter to all states in 2016. It didn't make so much of a difference. I just shared this with you. What needs to happen is also acceptance at state level. So this is a circular which you can see. This is Kerala. Okay, so this was written by the Excise Commissioner of Kerala, and they have said that in case so all these multiple licenses can be done except in the case of ENDs. Import certificate except ENDs. You understand? So they have eased it out. Whatever this is expired stock of these is drug controller is authorized. So you see, they have done something about making it available in Kerala, and you can see the difference. Statistics showed that. Divya Narayana, please mute yourself. Statistics showed that Kerala is much better compared to rest of India because of these proactive administrative steps. Okay, now those things have to happen at the government levels. Where are we now? It is 5:43. Okay, so we'll have a few more discussions, and or do you want to ask questions? Because now we are talking more about medical, our level. Are there questions that you want to take now, and then we'll proceed, or I'll finish and then you can ask? How do you want to do it, Priya? Shri Priya?
It's fine with anything, ma'am. We have 2 questions in the chat. Can we take that right now and then proceed, ma'am?
What are the questions?
Till how many days the drug can be prescribed for the patient?
So there is nothing written in the rules around how many days you can prescribe, but on an average, it all depends. When you're initiating opioid, we have to keep following up because the first prescription is never the final prescription. So you have to titrate, you have to review the patient, review how much pain relief, how much activity, are there adverse effects. So generally, initially, we prescribe for very short periods of few days, and we review the patient if it's on OPD. If it's IP, of course, we can. But once the patient's pain is stabilized with a particular 24-hour dose, then generally we give it for a month if the patient, is stable and if there are no other things that are expected. And we always, we have to give information in their own language that in case you feel these side effects, please stop taking medicine. So we need to ensure that adequate information is given to the patient as to stock it, store it in a safe place, not have access to the children in the house, and especially if there are teenagers, we need to ensure that it is away. So those things are done, and usually we give for 1 month. But suppose the patient is very far away, staying far away, and it's difficult for them to come and meet us. So we also give it for 2 months. But all this is arbitrary, which we from the Indian Association of Palliative Care, we have decided that not more than 2 months. Okay, but there are no specific written laws regarding how long. But in fact, what happens is the other extreme. Doctors just give it for a few days and then patient is lost to follow up. That is the most irresponsible way of prescribing opioids. If you're prescribing, follow up, titrate, adjust the dose, ensure continuity of pain relief and constant pain relief, and then you make the little longer prescriptions, but always review. If you have no way of reviewing, either through another center in another part of the country, handing them over, or through a local general practitioner, or through a proxy coming and visiting, or through a home care, do not start, okay? Because it is unethical to prescribe when you don't have a way of follow-up. Next question.
Ma'am, the second question is, what is the
whoever
validity?
asked it, is it okay? Is my explanation okay? Are there?
Dr. H.K. Das, is it okay?
Yes, ma'am.
Okay. Next question.
Okay, so the next question is, what is the validity of patient's E&D prescription once issued from RMP?
So that is what I said. So you have to write, this many tablets are being given for, this is the dose and this is the duration. You mention it. So it is valid only for that period. You're writing, say, 24th of February today, and I'm giving the tablets till, say, 23rd of March. So that is the validity. But validity of the drug depends on the expiry date. The validity of prescription is based on the prescription date.
Thank you, ma'am. I think we can proceed, ma'am. There are a few more
Ma'am,
questions.
can I ask one question?
Yeah.
Yes.
Yeah, ma'am, when we are writing the prescription, we write for maybe 1 month, but the person who is dispensing the drug, the nurse or the person who is responsible for dispensing, sometimes they give less because of the stock which is there, depending upon that. So is that okay?
If there is no stock, there's no way of prescribing. But what you
No,
need
no, there is stock, but they think that maybe we'll have many more patients, so we'll give it for 15 days. Or this patient is very far off, so we'll give it for 2 months. But my prescription is for 1 month. But
So
sometimes they
definitely
give
the
more or
palliative-
sometimes less.
Suppose, Manisha, you are the doctor in charge of your institution for these prescriptions. You need to ensure that your prescriptions are, acknowledged and followed as per the prescription. If there is a discrepancy, you need to have a meeting with the pharmacy in charge and elicit their concerns and find a solution mutually. And only then it can be sorted out. Otherwise, what happens is you will give a review date of 1 month and patient has finished the prescription in 15 days and they will suffer. Then you have to do the titration all over again. Or, some untoward event like even suicide can happen. So it is our responsibility as doctors that if there are discrepancies, we need to sort it out by meeting that particular department. Maybe we can have a class with them. We can elicit their concerns and find a mutual solution.
So it should always, the prescription should tally with the amount of drug that is being given.
That's correct. And
Okay,
it's the
thank you.
responsibility of the pharmacist to call you and tell you the drugs are over. And so I cannot give more than this. So then you will tell the patient to come back before that drug finishes so that, you can review and continue the next prescription. But to call a person who's in stable pain relief with a fixed dose every other day for a prescription is also wrong. You need to ensure that you have adequate stock. So according to the rules, you're supposed to look at your requirement for the previous year. Suppose you have used 20,000 tablets in the 2023. You're supposed to order at least 30,000 tablets for 24 because your practice is going to increase. Suppose you have ordered 1 lakh, you have to ask for 1.5 lakhs for next year because each time the patient number increases. You should avoid this interruption in supply by looking at your previous year and asking for the right quota. You understand?
But that is also a problem, ma'am, because the drug controller in our state, they do not want to increase, even if we give them an increased.
That's what I'm talking about. So all these are a lot of lack of awareness at the government level, at the official level, at our level, at different levels. So that is the reason I think Pallium India is very much there to support any institution which requires, they are a WHO collaborating center for ensuring opioid availability. So if you are having an issue that particular state, you inform them and they will probably arrange for an opioid availability workshop, which will include educating from the government departments, and also they will come and visit your hospital. So you will have some support. Okay, that's the way to go.
Thank you, ma'am.
So shall we proceed with the...
Yes,
Ma'am, what is the dose that we can start morphine tablets for an adult 50 to 60 weight?
So if I answer that, Sri Priya will be upset because you have had classes on that.
Okay.
How do
Fine.
you
I will-
use morphine? How do you
Yeah.
titrate? What are the essentials you need to look into? And we will be going out of the main scope of this talk. But
Sure.
if you ask Dr. Patel, he will be more than helpful. And you
Sure.
must have already had a class. Okay.
Thank you.
The
Thank you.
best practices and the medical knowledge is not the priority of this talk. And if I get into it, it will be a bit, traveling beyond the scope.
Thank you.
So there are, what I can address is, one I addressed is the government level issues, which even Dr. Manisha was, concerned about. It's a reality in other than Kerala and maybe Telangana and maybe some parts of Delhi. Most states are still struggling with the government officials and getting access, etc. And that we have to work separately. And I told you some of the barriers and some of the ways in which, opioid availability workshops are still done. So now the second aspect is ourselves. We have a lot of fears to prescribe or not to prescribe. And often these fears come under three headings: fearful of debilitating adverse effects, fear of overdose death, and fear of overdose death, mainly respiratory depression. Third one is, will my patient get addicted? So these are the three things which stop us from using it in patients who have severe pain and who are not doing well with step 1 and step 2. So we avoid it in patients who are, because they are fully functional, we avoid. Patient is not near death, we avoid. Patients who are very sick, we avoid because patient is sick. Patients who are old because they are elderly. Patients who are children because they are too young. That means literally most patients, we are fearful of using it. So this, definitely the previous questionnaire, whatever she asked, is correct. We don't know, clearly, because during our training, we haven't learned. So we keep imagining the worst, and we are used to seeing the injectable morphine, which has all of these side effects. So the perceptions are far more powerful than the substance of the law. So there is an WHO analgesic ladder which came out, unfortunately, 1 year after our NDPS Act came out. 1985, the Act came out. 86, the ladder came out. It clearly talks about how useful that medicine is, but it took so long for people to accept it. So in the same way, now the WHO analgesic ladder is probably being taught in MBBS level, and most people will know how to use it. So awareness and education is the key. So even when you are prescribing, some other doctors in your own institution will say, what are you doing? He's a young person, and just because he has cancer you're giving, his prognosis is not so bad. So this prescription has nothing to do with prognosis. It is to do with the severity of pain. Okay, so that's an important championship that you have to do within your institutions. So professional attitudes, sensitive to suffering due to the severe persistent pain, and competence in treating the pain effectively. Okay, so our attitudes over suppose we have no drug and this person is screaming the lungs out, we will probably move out of that place, because we become apathetic because we don't have anything to offer. That is because the drugs were taken away while we were learning and we were under training. Now that we have learned competence, we become more and more sensitive, and we are, that attitudinal shift has to happen. I showed you that elephant where everybody is trying to see the tumor, whereas the patient has come to them with pain, and that is neglected, as we saw in the RCC study across India. So we also have responsibility to train ourselves in the best practices in prescribing opioids, detect potential for addiction, know what to document and what to monitor, and also support the government in terms of awareness creation. And with the patients, we need to have a single prescriber. And while we are giving the prescription, the patient and the son or daughter may not ask you, but as soon as they see tablet morphine written there, they will say, "This doctor, he's too much. He's going to make my mother an addict, or my mother is going to be now bedridden." So they will not ask you. So it is very important while you are considering giving a prescription, you should elicit and address all fears. Let them come out. Will this cause kidney failure? Will this cause addiction? Will my mother be admitted in ICU because of this, stopping to breathe? All these things can come up. And the prescription has to be written very clearly and teach them about safe storage. So all these are our role, our responsibilities, keeping ourselves updated as well as keeping the patient safe. So, and we also call for regular follow-up. So we cannot give just long-term prescription, not follow-up. That is a very unethical practice. Okay, so many of these, person who questioned about, how to start and how to titrate and all, I will be sharing some links, which is coming under the National Cancer Grid web page, where we have, that is an MCG e-learning portal, which is, just have to register, it is free. And there are multiple modules on how to use, how to start, what to look for and everything. That link I'll be sharing later, okay? So there are other issues also. There is a push for expensive opioids. So the fentanyl patch, even if your patient is in a forest, they will get, because it's got a high margin of profit. So the representatives from pharma will ensure it reaches the patient. They'll come and tell you, "I will do home delivery, ma'am." So you'll end up writing patches. And you must have learned from your theory that we cannot start with patches. We have to start with immediate release preparations and then slowly move on. And then once the pain is stable, pain relief is stable, you move on to long-term medication. So here you can see sustained relief preparations and patches are mostly pushed. And you can see the date here, December 23, very recent. So we need to also remember not to succumb to the pressures from the medical representatives and always use immediate release morphine where indicated. And these are the cheapest also. So that is another precaution. Now, this lack of access is being seen. This is also, you can see last year, September. What can be done to improve the access? So the story continues despite different activism across the globe. And there is a morphine manifesto. And you can see that many NGOs across the world have signed up to work to ensure the, improving the safe access to immediate release oral morphine. Immediate release has come because of the push for sustained release and the patches. Okay. So we need to remember that we can be easily drawn by the speech of the representatives. So besides the medical knowledge, we also need to be sensitive to these aspects in our practice. Okay, so our responsibility is to list them. The state departments have to accept the drug reforms in spirit and facilitate balanced implementation and stop looking at every patient as a potential addict. Hospitals and professionals have to develop proper palliative care services, and the faculty, medical colleges have to develop sensitivity, and sensitivity is also important, and the capacity to use these medicines, because patients' care is important, not just cure. So all of them have to work together to make this happen in a way in which we have adequate access. So currently what I understand is if 100 people need morphine in India, less than 4 get it. That is a very poor state of affairs. Whereas if you go to Europe, if 100 people need morphine, 80 to 90 get it. Okay. So what should we do? We should familiarize and support the drug control officials by studying the law, the processes and all that. And so that we can go and, improve the problem in the state. We have to address the concerns of the excise department, because sometimes they feel that they were in charge of everything till now. Suddenly something is going away. So we need to help them understand it is just 6 drugs and all the hundreds of other drugs are still under them. Then only they understand. Okay. Then is the workshop, but you'll need NGO support. And there is, in the National Program of Palliative Care 2012, which is available under Ministry of Health, there is the standard operating procedures for a workshop is being outlined. You can take a look at it, and you should activate monitoring and record presumption things. Now, besides all these self-education, ensuring safety of patients, and stocking in the institutions, we also need to ensure that we are having this balance at all levels. And I will focus primarily on the balance that we have to maintain in our own practice. So the standard operating procedures and monitoring. We mentioned about, keeping those registers properly, monitoring the usage patterns. If a patient is going on coming and saying, I lost the prescription, or, my dog ate it, or something like that, going on trying to get more and more prescription out of you, you need to keep them under surveillance and check if there is aberrant behaviors. And we need to ensure that we are part of the dialogues between different agencies in the region so that misuse doesn't happen. So there was one study done from the Institute of Palliative Medicine. It was published in the Lancet. And they studied home care patients over 2 years, 1,723 patients. And they noted the quantity of morphine received in each stop and recorded the dispensing in the stock register, and it was all returned. Even they accepted return of leftover medications. They did not find any instance of abuse or diversion, and the primary reason they found was the record keeping by the staff. So ensuring a pill count, ensuring that all the dispensed drugs are recorded, and when a patient comes back for a prescription, check, did I give him 50 tablets or did I give him 100? Is it right for this patient to come back? Have they used it as per prescription? So all these things are the most important aspects of preventing misuse and diversion. And also I told you what are the features of addiction potential. So all the problems that we listed, let us see what are the solutions. So to state controller office not being activated, we need to get the order, because whatever we say, if a state drug controller comes under Ministry of Health, so it's a Department of Health in the state. So if the Delhi Joint Secretary from the Division of Revenue under Ministry of Finance writes, it is of no use. We have to get the Principal Secretary of the state to give an order. Only then will the Drug Controller Office listen. Okay. Then lack of awareness in the office is by opioid availability workshops. Complex procurement procedures, state level standard operating procedures in place for RMI, recognizing the medical institutions. So these are all one after the other. The no training experience in using is by training in RMI competencies, I think, which you have undergone in all these 19 lectures, and today is kind of wrapping it up. Then misconceptions, and again, I'm sure you all will have a 1 month of clinical observation. So you'll actually see patients who are prescribed 15 and 20 milligrams every 4-hourly, coming over, walking, they are doing their work, they are driving car. So the practical exposure to safe and rational use and what to monitor, what are the signs of adverse effects, all that, unless we see, just by reading theory, you won't get the confidence. So only when you see and really work with the people who are regularly using it, you will get the confidence. Only then will the misconceptions go. And threat of harsh punishments is by maintaining good records. Stocks, patient registers, all have to remain up to date. And that is the only way to overcome poor stocking, under treatment, and poor demand. Adequate access and availability. Okay, so these are the solutions. And if you want to get a sort of summary of what I spoke today, this is it's an international journal, Journal of Pain and Symptom Management. So we published an article called Civil Society Driven Drug Policy Reform in India. So this has sort of a story over 28 years of work that went into amending the Act in India. And this was published in 2016, just after the amendment. Okay, so if you feel like, you can read it, and it's a summary. It's like a, sequentially what happened in 90s, what happened in 2000, and what are the brief history, everything which I spoke briefly today is there in a brief form. So this tug of war between preventing abuse and, ensuring availability goes on. And unless we address the social economic determinants, which is poverty, which is lack of employment, socioeconomic status. So those are all beyond us. So you should know that there is always going to be a vulnerable population. For full realization of this balance, we have to address the vulnerability and risk behaviors. Okay. Along with that, as I told you, currently, if I am held with some medications which are beyond what I can prove myself to be authorized for, I can still be punished just like a drug dealer, because currently there is only drug control agency. There is no separate entity in Delhi which looks at the licit part of using opioids. There is a single agency which is generally run by the revenue as well as by the the law and order, means the criminals. So we need to create a licit entities, and if there is a clerical error in our record keeping, it should have a much milder punishment. Okay, so now it is all the same. So that is an issue. So I hope that today we have covered how the amendment has eased procedures as doctors, as registered medical practitioners, that we need to have some idea of what is required for RMI competency. Third is that we are at the center of safe and rational use, and we can prevent misuse and diversion of prescribed drugs by following the regulation prescribed mandates, and keeping the record, double locking, and ensuring the prescriptions are triple, storing them, allowing for an open inspection when it's required. Barriers can be managed through improved awareness. So it becomes, suppose I am the only person who knows how to use tablets, it's my job to ensure that it reaches the undergraduate students in nursing, in medicine, and the postgraduate students, so that they become better doctors and they become more sensitive and more empathetic to a person in pain. And we may need to champion the cause at times in the State Department, because all that knowledge becomes useless if you cannot stock and dispense opioids. So you may need to work through some civil society support or NGO support with the State Department of your place. And this needs continuous work. Improving access and ensuring balance need continued work. And so this person, let us hope that less and less like him, we can put an end to such needless suffering. Thank you. So we have still, I think, 20 minutes for more questions.
Thank you so much, ma'am, for such an elaborate session. Ma'am, we don't have any questions in the chat box as of now. There were few questions, but I have answered that in the chat box itself. But if the participants have any questions, I think they can unmute and ask right now, or they can also post in the chat box. We can take it up now.
Yeah. Go ahead. So you can raise your hand so that, Priya can follow by name. You can put a raised hand in the Zoom page. Prateek Jeevdas, go ahead, unmute yourself.
Good evening, madam.
Good evening.
Ma'am, I have a doubt.
Yeah.
If we have a medical shop of our own in our setup, what is the? I'm from Tamil Nadu. I am a maxillofacial surgeon. So, what is the protocol to store morphine and
Okay.
is anything
So if
important we
suppose
should know?
you have a clinic which is having, say, surgery and OPD and all those things, and you also have a pharmacy,
Medical license.
yeah. So you have to, if you are undergoing training now, you can apply for making your center an RMI. The whole clinic becomes the whole center becomes an RMI, because you are now trained. So in your name, the RMI authorization will come. I think Tamil Nadu is one of the progressive ones. So maybe, you need to contact people from Adyar Cancer Institute to know the procedures in Tamil Nadu, whether state drug control is already aware of the RMI requirements, etc. So I think they have amended state level. So the drug control is probably aware of it. So there are some application forms. So I'll be sharing some references. I think I didn't.
Okay.
I will share it with in the chat right now. And those reference, so you can apply using those forms and become an RMI. Then what happens is your drugstore in that clinic becomes part of the RMI. So then
Okay.
you can work through the RMI license. But suppose
Okay.
there is a chemist which is not attached to RMI.
Okay, ma'am.
They are bound by both the central NDPS rules as well as the state, the Drug and Cosmetic Act. So there you have to maintain all the 6 licenses as well as have the RMI authorization. I hope
Okay.
I'm made clear. I'll just give me a minute so that I give you the references in the chat.
Okay, ma'am. Thank you, ma'am.
So the amended rules at the government site, there is a link. Then guidelines for stocking, this we prepared, and it is uploaded onto the Tata Memorial National Cancer Grid site. And so guidelines for stocking and dispensing ENT, essential narcotic drugs. And all the forms, they're also there. And I have also given a link to a movie which just shows how severe, how badly people, life before death, it was a movie just to create awareness of how severe pain can be and how undignified the death can be because of unaddressed pain. So you can copy paste these and keep it in your resource. I can see Sheila Rathod. Go ahead, Sheila.
Good evening, ma'am. So, I am a private practitioner practicing in Mumbai. So, I don't do much of palliative care practice, but I do home visits in my area. I do a lot of home visits. So, my morphine prescription is not, I usually prescribe fentanyl. I prescribe only once or twice morphine, and it's easily available in my area. It's easily available. With triplet prescription is easily available. What I want to know is, since I had just owned my clinic, just one clinic, if I want to keep, if I want to stock morphine, which I'm not using it very frequently, should I do, or it's, since it's available, I don't have to do that?
Yeah, so it depends on how much at the end of this fellowship, suppose you're, changing your clientele and you're going to see more and more patients. And if you foresee your clinic is eligible to become an RMI, and with your
Okay.
training, you can apply and make your clinic, even if I read it out, no? Definition of medical institution includes
Yeah.
even a single person. So you can become an RMI, but then you'll have to take the charge of all the stocking, dispensing, maintaining registers, or you can employ someone to do that.
But I don't have a pharmacy attached to my clinic. Still, I can just keep, I don't have a pharmacy.
You can,
I
but
can
that
still,
it'll be difficult to maintain stock and all that. So most people, they don't do it in single person practice, but it is allowed as per the law. Second thing is you have access to it around.
yeah.
Patients are getting and the prescription is being honored the way you are prescribing. Of course, you don't need to, unless
Then
your
no.
become so heavy that you need more with you. So
Right. Okay. Thank you.
I can see Manisha has raised hands. So Priya, I can see only one screen. If you see more, please call them. Manisha, go ahead.
Yes, ma'am, I have 2 questions. One is that when there is an inspection by the drug controller, does the doctor need to be present at that time? Is it mandatory?
I didn't understand. Doctor needs to be present at what time?
When the drug controllers, they come for the inspection,
Uh,
the yearly audit.
like for example, in my hospital, it's a huge hospital, 2,000 bed, and so many departments. So they go to the pharmacy. So their pharmacist, the in charge pharmacy is the one who deals with them. Usually, if there is an issue or there is a clarification or something, then they ask me. Otherwise, on day-to-day basis, I don't need to be. But if you're a small place and you are directly dealing with it, probably you will have to there because nobody else will know what's going on. But if there is a proper pharmacy who understand what they are doing, you don't need to be there.
Okay, and ma'am, there is another question that can the same person be an I am the RMI in my institute. In my institute, I am the person responsible. So can I be the person responsible for some other institute where I am not working?
Of course not. Absolutely not. So it requires a full-time employed staff.
Because some people, they've asked me if my name can be put.
No,
So-
it is not as per the law. As per the law, you have to be employed in that institute and you have to be shown as a full-time staff. And you cannot be RMI in many places. No, it's against law.
Oh, thank you.
What about home visits, ma'am? If someone is
Yeah.
just doing home visits, then like individually, like you start to think, okay, I'll do home visits on an individual basis. Then
You'll have to have so home visit alone does not become an RMI. But if you have an office or you have a connection to an NGO, you can. But a car cannot be a double lock system, or a vehicle cannot be a double lock system to stock and dispense. So many, like for example, Pallium India is an RMI, for example, and all their home care vehicles can carry the drug in the name of Pallium India. But suppose there is a freelancing person doing home care alone without an address for a clinic which you can register as RMI, you can. It is taken as part of a service, which is.
thank you, ma'am.
Madam, I have a question. If I am a visiting consultant to a hospital where morphine is available,
Yeah.
I'm a visiting consultant. I'm not a full-time employed person.
Yeah.
I can ask my patient or relative of the patient to go with the prescription there and acquire the medicine.
So suppose just to imagine that you are in Bangalore and you think this patient will do well, and you have given prescription, and patient comes to St. John's because St. John's has stock. That person who's coming from outside will have to register with the palliative care department of St. John's, because primarily the responsibility is taken by the institute which is dispensing it. So I will look through your prescription, and if it is all okay, I will just make another prescription with triple prescription and everything, because prescription has to be from the RMI. The patient has to be registered in St. John's. I cannot give medicine for a person who is registered somewhere else. So that person will have to first register with St. John's, and then I will give a prescription, and then he will get exactly as you prescribed it. And it's my responsibility to also ensure that the prescription is rational. So I will also ask a few questions regarding the comorbidities and the creatinine is okay. Should I give TID or should I give 4-hourly? All those things also I have to judge, because any complication coming out of the prescription is on my name. So I will have to review, and it will be honored as you have written if it has been thoughtfully done. Otherwise, I have the right to change the prescription also. I hope you understand, Dr. Prasanna.
Yeah, but my question was, madam, I am a visiting consultant to a particular hospital where the morphine is available in that chemist shop, that pharmacy. So my patient who requires morphine, I can write on the prescription, on the triple prescription, which will be honored in that chemist where even other drugs which normally I write, which is not morphine, is honored.
Okay.
That
so what you're saying is you are referring the patient to only the chemist.
Yes.
So that
yes.
chemist, if they have a valid multiple licenses and they have their own independent entity, means like they are licensed chemists to stock and dispense opioids, you can directly send it. But if you're sending it, suppose that chemist is part of the big organization, and they are having the authorization only because of the RMI status of that institution, then your patient will have to register. I hope you find the difference.
Yes, these are two different things.
Yeah.
Here I was just saying that the hospital has got the pharmacy which is dispensing morphine.
It's having an independent license of its own, and it's not dependent on the RMI of the hospital. Yes, your prescription, the chemist can honor.
Yes.
Thank you. That was a good question. I think it will help many others.
Yeah, thank you.
Sai?
Hello, ma'am.
Yes, go ahead.
So, is there an average amount of number of tablets to be prescribed in OP, or like when you give the refill and all? Is there specific quantity, ma'am?
So as I told earlier also similar question was asked. So if everything is stable, patient's pain relief is adequately controlled and it is staying stable, I can give up to 2 months. It's not necessary that I give 2 months. If I want to review the person earlier, I will give for lesser time. But I can give up to 2 months. Like I'm in Bangalore and somebody is in, Dharmapuri or Anandpur or something quite far away. I will give. Only thing, we ensure that there is a phone follow-up or, the bystander comes and reports if there are any issues. And we teach them properly that in case you face these issues, you will have to stop and come back. Okay? So that is
Yes, got it.
ultimately, it has to be safe and rational.
Got it. Thank you.
Is there anyone else? I saw Dr. Jyoti. Go ahead.
Yes. Ma'am, I just wanted to ask if I have two different locations where I work. Can I register both the locations under a single RMI? I'm in the head. Is it possible?
I don't think so. If they are geographically different, it cannot happen. The management, the administration, the location, everything, if it is different, you
Yeah.
can. But two
I
buildings,
cannot.
you cannot.
Okay. Okay. So then in that case, if I'm doing my practice of palliative medicine at two different locations, I'll have to have two different RMI certificates for both the institute to prescribe to having the prescription, get honored at both the places.
That is correct. But you cannot be the RMP in charge of the RMI in both. You have to
I
say,
see.
you can be RMP in charge only in one.
I
And
see.
other,
Okay.
you have to find another doctor who's trained. Because
Okay.
two
Okay.
institutions cannot use your training and ask for the license. Only one place.
Okay. So the dispatch can. So it is possible at only at one institute. It is that.
For the other, you have to find another person who's having the adequate training.
Yeah. Thank you. Thank you.
Next. Is there anyone else? I don't see any raised hands.
Yes, ma'am. I think there are no more. And in the chat box also, all the questions have been answered, ma'am.
Okay. So congratulations on doing a course. I hope whether you become full-time practitioners or just, occasional practitioners, I'm sure this course has opened your eyes to a completely new dimension of looking at patients as a human being and, empathizing with their concerns and wishing you all the best. Do well.
Thank you, Dr. Nandini. It was really enlightening to listen to your talk. I think most of the participants got many new information from that. And we believe this was the best way to close one batch. Thank you so much for joining. I personally know how held up you are, how tight your schedule is. Still, you found out time to join us and enlighten us on this very important topic. Thank you so much for that.
And if you could, share those resources links into your this team, I think, so that they have it. Because once we close the Zoom, the chats will disappear. So if you could copy paste and give them.
I have already done that now. I have already shared it in the WhatsApp.
Okay, thank you. All the best. Bye.
Thank you, ma'am. I request all other participants to stay back so that we'll be taking just some verbal feedbacks from you all. Dr. Hashmat, would you like to start?
Yeah, thank you so much, everyone, for joining today and also for all the sessions previously. I think it was a great season, FCPM 31. And we would like to have your verbal feedback also so that we improvise on what has to be done in future, because that is how we also grow. So I request you. So I request you to, raise hands, unmute and speak, or else please post in the chat box regarding your comments so that we can take it up further. Thank you, everyone. So it was a very great season with all of you, for me especially. Thank you.
Anyone? I think
Yeah.
yeah.
Yeah, good evening, ma'am. So I had an excellent experience. I really learned a lot. I mean, from this, previously also I had done a course with Pallium India. What I would like to say is, ma'am, the assignments should be discussed in groups. That's what I feel. That the feedback I could give. Because then sometimes we are not sure. Like we have doubts. I mean, you have given us the markings. I mean, whether we are right or we're wrong. But then we have so many doubts in that. Why was it wrong? What can be what can we do? You ask us to message to the faculty separately, but it would be better if it's discussed in a group. I mean, so that all our doubts get cleared and we are more sure that we have learned it the right way. I mean, as one feedback which I mean that should be discussed. I feel the rest the experience was awesome.
I think that is what everyone feels in the group, that there should be a separate discussion of the assignments. That is what I have felt with the whole group. Everyone wants the same thing. But what I would like to say is we've had really very good faculties, all of them, excellent faculty selection, and everyone has been very helpful, very informative, and very interactive. So if we could just have these assignment discussions, I think it would be much better. Thank you.
We do take that point much into consideration, doctors, because even in our previous batches also we used to get the same feedback. Only thing is our limitation is our we work on our SOPs and guidelines, and which has not been revised for some time now. We are also recommending the same for revision with our management and core committee. So let us hope that something happens in the near future. But for the time being, unfortunately, this is my only answer. You are free to discuss whatever doubts you have with the facilitator or Dr. Sridevi. And yes, of course, these suggestions are well taken, and we will definitely see what can be done about that. Thank you so much. I typically see one comment, Dr. Hashmat, you may have to address this. Addicted to all classes more than opioid. Dr.
Yeah, I just saw that. Thank you so much for that. Yeah, I could also see all the comments here in the chat box. We have got positive response, and yes, obviously, as you had Dr. Manisha and Dr. Sheila, as you mentioned regarding the assignments, I could see in the comments also there is no comments regarding assignment discussion. So we will discuss it along with our team, and then we'll come up with a plan for that too in future. We will definitely consider that. Thank you.
Another thing which I wanted to ask you, that when we have a hands-on training, at that time, do we have any theory classes or just home care visits? And does that also have an assignment after that?
If you are asking particularly about the global fellowship program, ma'am,
about the global fellowship. Yeah.
During the observation period, there will be some classes, like it would be one-on-one sessions or even group discussions we'll be having, theoretical, along with the home care visits, plus discussions in the OPIP settings as well. As far as I know, you'll be required to keep logbooks of all the works you're doing there, doing at that time. Otherwise, no such assignments as such connected with this observation period.
Okay, thank you.
Thank you, Dr. Joel. Yes, same assignment point. Any other suggestions which you feel could improve our delivery? Yes, Dr. Das, we can see your hand raised.
Hello. I like the way the psychosocial part that was being dealt by various faculties regarding the approach of the patient and the collision issue that needs to be, that arises between a patient and a doctor, patient and a relative, or doctor and a patient. So these things were quite usually do in our day-to-day practice, but the thing is that should not happen. And that was a real learning experience for me itself.
Thank you, sir.
Good evening, everyone. For me, it was a very enriching experience. Actually, I want to say only the positive things because I did not find any negative points. To start with the timing, it was very well maintained. Every session was on dot, and the speakers were all extraordinary. I say they put their extra effort so that they can share their knowledge with us. And the interactions were too good. Not a single question went unanswered. And the moderators were also good. They did their job so good that even as they did not even leave one single question in the chat box. That's all is my point. Thank you so much. And waiting for some more good things to happen in the present. Thank you.
Thank you, Dr. Anasuya. We do also understand that in this particular batch, there were very lot of mix-ups which happened, which were unfortunate. Like initially there was another coordinator, facilitators kept changing, and then I came in. So thank you. I would personally like to thank each one of you to cooperate with us. You all cooperated with us, our team, in when we had this change of teams. Thank you so much for that. I personally wanted to thank everyone for that.
Sripriya?
Yes, sir.
Whatever hurdles that we have, that was encountered very smoothly, and every session has gone so smoothly that that no questions are, there are no lacunae in that. Everything went smooth. That's what I mean to say. Even after, as you said, that there are some hurdles out there, but things went smoothly. We didn't notice it. That's all.
Thank you, sir. Thank you so much.
Thank you.
And I personally want to thank Sri Priya here because she has been there all the time. Whenever, we felt we couldn't join or all these things would happen between us, but still she was there, very supportive. And the entire team of Pallium India was also supportive, especially the education and training team. So
Dr. Hashmat, you went on mute. I suppose it is your little bundle of joy who is crying, which is making you mute. Because just wanted to share, Dr. Hashmat is having a very small baby, I think 3-month-old baby at her home. And she has kindly consented to facilitate all the sessions, whichever she could do. Actually, she is on leave still. She is still on maternity leave and she is facilitating for us. I definitely would like to thank her from the bottom of my heart.
thank you, dear.
Any other comments, suggestions? Nothing else, maybe Dr. Hashmat, I think we can call it a day now.
Yeah, sure.
So any parting words from you?
Yeah, so over to you, Shri Priya, for the final closing notes.
Thank you. So thank you everyone for joining us on this wonderful journey of 20 sessions. And trust me, this is not going to be the end. This is just a start. We will definitely be maintaining the WhatsApp group as it is active, and we'll be sharing all the major updates in the field of palliative medicine as well as about new courses in that group. So we would humbly request everyone to be a part of that group, and please do not leave so that you get regular updates from us. And you already have the numbers of our telehealth department and our numbers and email IDs as well. Whenever you are in doubt, please do feel free to connect with us. We will do whatever we can to support you in your practice. And we do sincerely hope that whatever little knowledge we were able to impart into you, you will find it useful in your day-to-day practice. And alleviate pain and suffering for people around you. So wishing everyone very good luck and bright and prosperous career and practice. This is Sri Priya along with Dr. Hashmat Fagana signing off for the last time from the Tips Eco Hub. Stay connected, everyone. Let us make the world a better place to live. Thank you. Bye-bye.